My name is Connor, and today I'm going to be talking about the anatomy of the hip in relationship to a total hip replacement. Okay, I'm going to try to use a PowerPoint, and I'm also going to try to put it down below as a link. So here we go. So first part of the acetabulum, or the hip joint, is going to be here in the pubic bone. So this whole thing is the pubic bone. You're going to have the ilium, the pubis, and the ischium all come together into this center portion called the acetabular fossa. Now the other part is going to be the lunate surface, which is going to come out and kind of round it out like a cup. So this slide goes into more detail on the ball and socket joint of the hip. So over here we still have the acetabulum and we still have the lunate surface. But what is added is this ligament down here, the transverse acetabular ligament, and this is going to complete that circle. Okay, so it doesn't go all the way back into the fossa, as you can see. It creates this acetabular foramen going back here. So now going over to this side, we can see that the ball and socket joints, the head of the femur is the ball, the socket is the acetabulum. Okay, so the head of the femur is going to wrap around and go into the socket, and it's going to rest in this kind of circular area. Now what's coming out of this acetabular foramen is going to be this ligament that connects the acetabulum and the head of the femur, and it's also going to have the obturator arteries coming up, and it's going to supply that joint. Okay, so the other thing that you need to see from this slide is the synovial membrane, which is in green, and it's got all of the head of the femur and the acetabulum. Now the synovial membrane is responsible for the smooth sliding between the head of the femur and the acetabulum. So now immediately behind or closer to the surface are going to be these three ligaments that we can see in this slide. So we have the iliofemoral ligament, the pubofemoral ligament, and the ischiofemoral ligament, and this one is going to be posterior and these two are anterior. Now these are going to connect the three parts of the pubic bone to the femur. This slide is going to show us the muscles that are associated with the proximal end of the femur and the hip. These include the gluteus medius, gluteus minimus, piriformis, superior gemellus, obturator internus, inferior gemellus, and quadratus femoris, and they all attach to this proximal end of the femur. This next slide is going to show us two more muscles that are added on. And you've got gluteus maximus, which covers this whole area, and tensor fasciae lata going down towards the side. Now another important factor is the nerves running through this area, and the most important one being the sciatic nerve, which is running right parallel to the femur. The other one, kind of problematic for a hip replacement, is going to be this posterior cutaneous nerve of the thigh running through here, which is sensory to the leg. This picture is really nice in showing how many muscles really surround the hip joint that have to be considered, and it adds in psoas major and iliacus, which is coming from up this way and going to connect down to the femur once more. On this side we can see more of the arteries that have to be considered, and most importantly we have these medial and lateral circumflex arteries that wrap around this proximal end of the femur. Now that we have covered the anatomy of the hip joint, we can really move on to the actual hip replacement, and we can see that the damaged femoral head is going to be removed and replaced with a metal stem and a ball. We can see that right here. It goes into the hollow center of the femur, and right here's the ball that replaced the head. So then we also have to remove the damaged cartilage surface of the acetabulum and replace it with a metal socket. And finally, a plastic, ceramic, or metal spacer is going to be inserted between these two to take the place of the synovial membrane, and really rely on that smooth transitioning and sliding between this new ball and socket. And you can see that replacement of the synovial membrane is that little gray part in between. There are two approaches to a total hip replacement. The first one we're going to talk about is the posterior approach, which is less invasive, but you cannot see the hip joint as well as an anterior approach. So we're most concerned about is the muscle preservation and the risk of nerve damage. So for muscles, the gluteus maximus has to be split, but it does not require repair as the whole tendon is not removed. The piriformis muscle and the superior gemellus muscles also have to be detached and later reattached to the bone. And as you can see, that takes 4 to 6 weeks to heal. The risk of nerve damage is pretty low, especially for the sciatic nerve, which is really important to this surgery. The anterior approach will often lead to a better view of the thigh in its entirety. However, you have to often cut through the muscle bellies of tensor fasciae lata and the sartorius muscles instead of going in between them due to the higher risk of nerve damage, especially to the lateral femoral cutaneous nerve of the thigh, which provides sensory information. There's also a little bit of a higher risk to the sciatic nerve compared to the posterior approach. In this approach, you also have to detach the piriformis muscle, and it is not able to be reattached in this way.